Hi, everybody. Welcome. Happy Tuesday. Let a few more people trickle in here. Um, Welcome. We're doing a CE webinar today, which is so exciting. I haven't done one of these in a little while, and they're one of my favorite things to do. So I'm really excited today. We do a couple different webinar formats here for our CCRN reviews. Some are quick 30-minute practice question webinars that maybe you have already seen, and others are a little bit longer form, like today, where we're going to do an hour-long crash course style, a little bit more lecture heavy than just practice question heavy, and just work through some concepts together. I still like to keep it pretty interactive and take advantage of the fact that we are here live, and help interact with each other a little bit more. So feel free to ask questions. I might see them, I might not see them, but I'm not always perfect at that. You can use the chat to do that. And yeah, let's see what else. Like I said, today is that longer form, so we're here for an hour. Let me bump to this slide really quick. Like I mentioned, this is a CE webinar. So what that means is if you stick around for the extent of the webinar, or at least 80% of this webinar, then you will receive a contact hour certificate that you can use in case your state needs continuing education certificates, if your job needs that sort of thing. You can use this time to fulfill those requirements, which is super excited. We are accredited here with Archer Review at the American Nurses Credentialing Center, so the ANCC, and that's how we're able to offer continuing contact hour certificates. We have no relevant financial relationships and no commercial interests present for today's presentation. That basically just means I'm not going to be talking about a medication that I actually work for the pharmaceutical company for it. So there's no sort of kickback that I'm getting by promoting certain medications or devices or any of that. So you don't have to worry about any of that. As far as learning outcomes and objectives that I'm hoping that we will see today, what I'm hoping to talk about with this coagulation crash course, I want to talk about key coagulation lab values and apply those findings to our clinical situations. So when we're talking about different coagulation disorders, then we can talk about the lab values that are going to change with them, differentiate between those common coagulation disorders seen in critical care, like DIC, HIT, liver failure coagulopathy, we'll briefly mention as well. And then understanding the indications, monitoring, and reversal strategies for anticoagulant therapies. We'll talk about that when we get to the pharmacology here at the end of this presentation. Really quickly, before we get started here, we are talking about the CCRN. In case you're joining and it's your first one here, I just would like to give a little brief synopsis about the CCRN, especially for joining on Facebook or YouTube. Just want you to know that this is not an NCLEX preparation webinar. Not that you can't use it for that. Please feel free to stick around. This is still absolutely helpful nursing information. But it is very specific to critical care management of these conditions, instead of talking about the condition more in a general sense. So the CCRN is the Critical Care Nurse Certification. It's a certification that you can obtain after working in the ICU or the critical care setting for 1,750 hours, which is about a year full time. Can be done a little bit sooner than that as well. When you've reached that amount of experience, then you're welcome to sit for an exam and prove your critical care knowledge base. That exam is 150 total questions. You will take all 150 and 125 will be counted. Out of that 125, you need 83 correct to pass. That comes out to about a 66 to 67% score. Now, last year we saw a 72% pass rate, which is decreased from the year before that. It was in the like 81% range. So unfortunately, we're seeing that pass rate go down, which I hate to see. And I hope that when we get numbers back next year, it's gone up a little bit. Motivations to become certified, to become CCRN certified. If you're interested in going back to school, it's great on the resume, if not required. If you're going to CRNA school, you absolutely need to be CCRN certified. A lot of institutions, so facilities are providing some sort of payment for being certified. They will reimburse you for the cost of the exam sometimes, give you an hourly shift differential, a yearly bonus. There's a lot of different forms that facilities use to kind of motivate nurses to become certified because it's really good for them if they're employing certified nurses. And then if none of those apply for you, I know for me, when I prepared for my CCRN, I gained so much confidence at the bedside. Just the act of preparing for a test like this helps close the loop on so many different concepts. And that to me was really, really helpful. And I think that's the biggest motivation. If we can increase our confidence and competence at the bedside, that is super motivating. With Archer Review, we do have a CCRN product, which many of you might already be using. It comes with a 1,000 plus question Q bank, I should say, covering every single topic on the test plan, as well as 13 plus hours of on-demand video lecture content that's going to be kind of similar to what we talk about today. So this is kind of a good, if you don't already have the product and you're interested at what the lectures look like. I did all of the lectures, so it's my teaching style, so you can see if it's something that works for you or not, which is another reason why it's kind of nice to do these webinars for free and see if it's something that you want to take a whole course in. And then we continue to do these webinars weekly. So thanks so much for coming, everyone. We will go ahead and get started. Like I said, we're talking about coagulation today. Super exciting. Anyone want to tell me where you're joining from? If you've got a test date coming up for your CCRN, when are you planning on testing? I love just kind of getting to know who's here. These longer form ones are not as interactive as my practice question webinars, but I still like to interact as much as I can. So try to stay involved, stay interactive if I ask little questions. I don't know, it just is so fun. Good morning from LA, testing in 2 weeks. Oh my goodness. Yay, you're almost there. And I recognize your name, so you've been here before. Welcome back. Welcome back. Super exciting. 2 weeks. That's a great amount of time. Joining from Illinois. Awesome. I'm over here. I'm in Montana, actually. I haven't lived here forever, but I live here now. So we're all over the place. All right, Middle Georgia, hoping to test by the end of the year. Just started. Okay, nice. That's great. Just started studying. Yeah, that is a really great idea. I tell people all the time too, if they're new to the ICU, to go ahead and start the process of preparing for their CCRN just to help, like I said, like increase that confidence, bridge some of the concept gaps that you might be having. There's really never too early of a time to start studying. Even if you don't have plans to really take the test for a while, it's a really great idea. I've been an ICU nurse for 2 years now. Totally get that. I didn't take my CCRN until I'd been a nurse for 4 years, which there was really no good reason for that. Actually, I think the problem was a lot of the hospitals that I worked at that time weren't reimbursing for it. And now a lot of hospitals are. And I'm super happy to see that. Okay, awesome. We've got people from all over Kuwait. Oh my goodness. Pursuing a career in New Mexico. Awesome. Okay, let's go ahead and get started. So if you've been in any of my lectures before, if you happen to be taking our CCRN course on Archer Review, or just seeing any of these free webinars, you know that I like to start with normal. What that means is when we talk about a concept, I want to start with what is normal anatomy and physiology before we get into anything abnormal. I don't think we stand a chance at understanding pathophysiology. So when things are wrong, I don't think we stand a chance at understanding that if we don't know what the body looks like when it's functioning normally. So we always start here with anatomy and physiology. And since this is a coagulation crash course, we're going to talk about the coagulation cascade, the clotting cascade, and kind of give the high level details of what's going on with the clotting cascade so that we understand pharmacology better and we understand our disorders better. So coagulation is a normal function of our body. Our body is able to do this coagulation process in order to form a clot to stop a bleed. So if a bleed is occurring, there's bleeding happening, our body kicks off this cascade to stop that bleed. And the whole goal is to get to a fibrin clot. That is our goal, is get to the point of fibrin and have a fibrin mesh clot in place to stop bleeding. And then eventually we want to break that clot down so that the tissue underneath that clot can heal most effectively. And that's fibrinolysis. So the coagulation cascade will lead us to a clot, and then it'll also lead us to clot dissolution. With fibrinolysis, it's kind of operating on this negative feedback loop. When the clotting is no longer needed, it's going to stop, and we're actually going to start breaking down those clots. So when we talk about the clotting cascade and the clotting pathway, it's important to know that we've got a couple different types out there. We've got intrinsic versus extrinsic pathways, and that these pathways are going to tackle clotting slightly differently from each other, depending on if we're dealing with an internal bleeding injury or if we're dealing with an external bleeding injury. So if something happened that cut into the body from the outside, that would be an extrinsic source versus an intrinsic source, which is internal bleeding. Now, the good thing is that those different pathways do end up conjoining and meeting each other at something called the common coagulation pathway. So even though they start with behaving a little bit differently, using some different clotting factors to achieve a clot, depending, again, are we reacting to internal damage or extrinsic damage, they're going to come together and start tackling clotting in a mutual way, in the same way. And that's on that common coagulation pathway. Now, either way, whether we're talking about intrinsic, extrinsic, or that common coagulation pathway, we are going to be using lots of clotting factors to work together to form clots after injury. Some examples of these clotting factors that you may have heard of: Factor 1, fibrinogen. Factor 2, prothrombin. Factor 2A is just thrombin. It takes an enzyme to get to that active thrombin form. A factor X is Stewart factor, another one, or factor 10 really, that we see often in practice. The four main processes and aspects of that coagulation process is: one, we're going to see local vasoconstriction. When we have that injury to the endothelial tissue leading to bleeding, the vessel itself is going to constrict to reduce the blood flow to the area, which is really helpful if we're trying to slow bleeding down. So that's going to cause that local vasoconstriction, reduce the blood flow to the area to reduce the potential bleeding. Now, platelets are circulating all the time, all over. They're in our bloodstream, right? So platelets at that site of injury are going to start to change, and they're going to aggregate to the site. They'll aggregate to each other. They will split apart. They'll change in structure, and they are going to stick to that site of damage. Now, with that, the platelets are going to start releasing a bunch of stuff into the bloodstream, a lot of these different clotting factors, and it's going to get us to the point that we have a fibrin mesh. And that fibrin mesh is what's going to actually lead to a good clot. That's what we want, is a fibrin mesh clot. It takes a lot of clotting factors and a lot of conversions to get there. Now, after we get that nice fibrin clot, we've stopped bleeding in that location. Eventually, that tissue does need to interact again with the bloodstream in order to heal properly. We need to start breaking that clot down to allow for ultimate healing. And that's the process of fibrinolysis, so taking that fibrin down, and clot dissolution. That's part of our clotting cascade. So that was a really quick way to go through that. Let's look at those steps a little bit more in depth. This is our coagulation pathway, still simplified. The coagulation cascade, or the coagulation pathway, is very extensive, and it has lots. I mean, if you look up a picture of the clotting cascade and all the different conversions that happen and all the different clotting factors that are needed, there's a lot to it. So this is kind of the basics, but still a little bit more in depth than what I just went through. So let's go through it one more time, and that way we can increase that understanding. With this coagulation pathway, we're starting off with that initial vasospasm to reduce blood flow to the area. Again, after an injury has taken place to that endothelial tissue, the lining of the vessel wall. Now, at the site of injury, we're going to see those platelets be activated at the location of injury. Now, activating platelets is a whole thing. Platelet activation leads to a lot of different things. The platelets themselves are going to change shape to be able to adhere to the site of injury. And then they're also going to start to degranulate, meaning they're going to break apart. And in that process, clotting factors that are living inside the platelets are going to be released into the bloodstream so that they can be activated. So some of those clotting factors is factor 10, which is responsible for converting prothrombin into thrombin. Thrombin is going to convert fibrinogen into usable fibrin, and fibrin is what is going to string around that clot, allowing for full clot formation. So you can see how one thing leads to the next in this cascade. And these are just some of the main clotting factors that we see. Now, also in that, when that platelet degranulates, we're going to see some release of other things as well. Serotonin, histamine, adenosine diphosphate. These are all released into the bloodstream, and they're going to allow for even more vasoconstriction and platelet aggregation, kind of egging this process on to ensure that it continues to go until we have an adequate clot. That's when that feedback system is going to kick in, and it's going to ensure that the process stops when the bleeding stops. When we've got an effective clot, this is going to stop. We're not going to release more serotonin, histamine, and we're not going to cause more platelet degranulation because our clot is effective. Then we can start that clot breakdown process of fibrinolysis and allow for tissue healing. We have to get that clot out of the way to allow for that tissue to fully heal. And that's what this fibrinolysis process is. Dissolve the clot, allow for tissue repair. We're going to use plasminogen, which is always circulating in the blood, just kind of sitting there ready to go whenever this is needed. And it's going to bind to that new fibrin clot. The injured epithelial wall is going to release an activating factor that's going to convert plasminogen to usable plasmin. And that plasmin is going to rapidly deteriorate the clot. And that's how we get true fibrinolysis. Okay, we made it through the clotting cascade, everyone. That's a big deal. There's a lot to it. I know that's, we didn't talk about every single clotting factor. I wanted to include the ones that we often test in the ICU setting. Which ones do we see come up pretty often? So now I want to we've talked about this whole coagulation process, 4 main aspects of it, platelets, how they all work. How do we assess coagulation? And I've left this slide a little bit blank. What are we looking at assessment-wise? What labs are we looking at? What imaging are we looking at? Can y'all interact just a little bit and tell me what you can think of? What things are we looking at for our patients? Yeah. Okay, good. I'm seeing lots of labs. Absolutely. What other things? What other things other than labs? Yeah, there's some images. Perfect. Bruising, assessment petechiae, awesome. How is the tissue healing? Good question. When we have that clot breakdown process, when we've got a fibrin clot covering an area of injured tissue, the necessary blood flow with proteins, with glucose, things that kind of help tissue heal, it can't get there. So the tissue just has a natural cycle of healing over time, and we have to have that clot go away. Kind of think about when you've got a scab on your leg. Let's say you cut your leg, a scab develops, eventually that scab falls off, and you can start to see how the tissue kind of regenerates and comes together. But part of that process was the scab needing to come off in order for the skin underneath to come together all the way. It's kind of the same thought process. Okay, great job. Yeah, we got really good notes there. So assessment wise, we're looking at, are we seeing any evidence of bleeding? Sometimes this is really obvious. Do we have GI bleeding happening that we can see? Do we have external bleeding? Like, was there a trauma accident? What's the evidence of bleeding? Are we seeing stroke symptoms that maybe we're concerned about hemorrhagic stroke or even ischemic stroke? Do we have a clot hanging out up there? Sometimes it's not as obvious, and we have to use some other signs like hemodynamic status. Likely, if we're bleeding really significantly, our blood pressure's going down, hemodynamics become very unstable. Heart rate typically does what when we're bleeding? Does it go up or down? Yeah, right. Tacky. Yeah, we're going to get faster to compensate. New acute pain, specifically for the abdomen. If we're concerned for abdominal bleeding, then that will lead to an increased abdominal pressure, and our patient will describe pain from that. And then finally, do we have a trauma source? Is there something more obvious going on? Lab analysis wise, we have so many labs that we can send off for our concerns about coagulation for our patients. This is, again, if we're concerned about bleeding or we're concerned that they're clotting too much, we can send these labs off. If they're bleeding, we're concerned about how much blood is still left circulating in their body. So that's hemoglobin and hematocrit. Do we have enough red blood cells to oxygenate our tissues? Let's send off a hemoglobin. Platelet count. How many platelets do we have circulating? PT, INR, and aPTT are all bleeding time. So they're basically telling us how long does it take to form a clot. If we don't have as many clotting factors circulating, it's going to take a lot longer to get through that clotting cascade if we're waiting on certain clotting factors because we don't have them. And then our bleeding times are going to be prolonged, or you can even call them clotting times. How long does it take to form a clot? And that's going to be much longer, again, if we don't have necessary clotting factors. Fibrinogen is a clotting factor that we can send off and we can get a level for. D-dimer is a clot dissolution indicator. So this is referring to that fibrinolysis process. This is going to be elevated when there's a clot around, because we know that the when we went to this fibrinolysis slide, plasminogen is always circulating in the blood. It's going to bind to these new fibrin clots, and this whole fibrinolysis process is going to be activated as soon as we've got a clot on board. So a D-dimer can tell us what our clot burden looks like. Imaging wise, we can see clots and bleeding with a lot of these images: CT, MRI, ultrasound, and X-ray. So when we are thinking about bleeding and clotting, we've got lots of ways to assess our patients, which is a reason that I like hematology conditions, because we have a lot of information that we can look at and a lot of different ways that we can treat these problems. So that's kind of our basics. We're talking about coagulation cascade, including fibrinolysis. This is how we assess the coagulation status of our patient. Are we bleeding or are we clotting? Let's take a look at all of these different things. And this will all be used when we start to talk about our disorders. So let's go ahead and get started with DIC. I love DIC. I don't know why, but it's one of my favorite conditions. I don't love it when my patient's experiencing it, obviously, because it's pretty life-threatening. But it's just very interesting to me how it all comes to be. So it's just an interesting condition to me. So I like talking about it. So DIC is disseminated intravascular coagulation. Big, long name. This is characterized by when we are systemically activating the coagulation system, and that is going to lead to lots of clotting and eventually lots of bleeding. Can someone tell me what the other name for DIC is? We call it something else, and I really like this other term that we use for it. Anybody know what else we call DIC? It's okay if not. I don't hear it all the time. I just like it. We call DIC consumptive coagulopathy. And the reason for that is we are triggering this coagulation cascade everywhere in the body. It's systemic. So we're causing clots to be born to occur everywhere. Eventually, we only have so many clotting factors to go around. If we're making clot after clot after clot, we're going to use up all those clotting factors, and eventually we won't have any more ability to make a clot, and we will start bleeding because we have consumed all of our clotting factors. And that's why I really like that consumptive coagulopathy term. Now, with etiology, I want to bump over here really quick. With DIC, DIC is not a condition that you're just going to develop spontaneously. It has to be triggered by something else. There's no like idiopathic DIC. Sometimes we can't totally figure out what caused it for a patient, but something did. The body's not going to spontaneously go into this. It is triggered by something else, kind of like ARDS in that way. ARDS usually has a trigger, an inflammatory trigger of some other kind. Now, as far as etiologies are concerned for DIC, the ones we see the most common in the ICU, it's sepsis. Sepsis triggers DIC, and that is what I am seeing, at least personally, in the ICU all the time. Now, other things that can trigger it is trauma, hematologic malignancy, so any presence of cancer, liver disease, because our liver is responsible for creating these clotting factors. So if there's something going on with our liver, it can cause DIC. Transfusion reactions can lead to this. Burns and obstetric complications like preeclampsia is a eclampsia, an example of that, as well as a few other obstetric emergencies. So there's something going on that triggers this response from the body and triggers the systemic coagulation activation. With this, we have a risk for micro and macrovascular obstruction because we're making clots and sending them everywhere. So we can obstruct blood flow to many different places. Over time, it's going to deplete our red blood cells, platelets, and clotting factors, and that's where we get that consumptive coagulopathy. We're using up all of these clotting factors to make all of these clots. It's an endless positive feedback loop. So it doesn't work. Something has happened to our clotting cascade. It's not going to turn itself off like it normally would. It's going to keep going, keep creating clots until it can't anymore because it's used up all of the clotting factors. That is what's going to get us to a potential of bleeding or hemorrhage as we are no longer able to form clots where we actually need them. So let's talk about how our etiologies get us to this point. When we're talking about sepsis, sepsis is going to trigger inflammation everywhere. It's typically a bloodstream infection. We've got a massive triggering of inflammation. Inflammation is characterized by an endothelial damage that takes place. We're causing damage to the endothelium. Endotoxins are released when we're in that massive state of inflammation. Those endotoxins are going to trigger that clotting cascade. Now, again, clotting factors will be used up, and that will lead to bleeding. Burns and trauma are another reason we could see DIC, and this is simply because we are causing endothelial damage directly. With burns, we're burning through that tissue. With trauma, we've got some sort of injury that caused a massive amount of endothelial damage. The whole body kicks into overdrive trying to fix all this endothelial damage, and we end up using up all of our clotting factors. So let's talk about assessment. What are we actually going to see with these patients? Kind of depends on where their symptoms are located. So first of all, when we're looking and thinking, could our patient be in DIC? We're thinking through, do we know of a cause? Because like I said, this isn't going to just happen spontaneously. We need something to have triggered it. So are we taking care of a patient who has sepsis and now is in septic shock? Then we could think, well, maybe this is why their gums are bleeding, because maybe their sepsis triggered their DIC. We know something about them that is a trigger for DIC. What we're going to see is, bleeding from multiple sites. We can see it from the gums, nose, ears, eyes, bleeding from all of your IV sites, really abnormal bleeding, because those are areas that normally the body is able to make little clots constantly to protect those areas that get small little abrasions. But we've used up all of our clotting factors, and now we're doing really abnormal bleeding. Widespread petechiae. This is because we've used up a lot of platelets. This is a classic sign of thrombocytopenia. Cyanosis. If we're throwing clots all various places, we can throw them into peripheral vessels, and we could see areas of cyanosis. Organ dysfunction. Where are these clots located? We've made a ton of clots. Where are they? Are they in our renal artery? So are we reducing perfusion to our kidneys? Therefore, we might see some hematuria and oliguria. If we're really massively bleeding as well, we're also reducing perfusion to our organs. Pulmonary embolism, is that where a clot was formed? Well, we'd see hemoptysis and dyspnea. Ischemic or hemorrhagic stroke, we can see either one because we can have bleeding or clotting. Coronary artery occlusion. Are we seeing chest pain? Because now we've got a clot in our coronary arteries. Liver failure. Have we obstructed blood flow to the liver? Bowel or mesenteric infarction. This one can be pretty common. Our mesenteric artery can get a clot in it, and we can experience bowel infarction very quickly, and have necrotic bowel be a concern. So we don't know the clots are forming everywhere. So you're really going to look at your patient and see, where am I seeing organ dysfunction? That's where I'm concerned for a couple things. Is my problem that a clot has lodged in my renal artery, or is my problem that my blood pressure is low because we're bleeding somewhere and we're lowering our blood volume? And that will help you determine where these clots are located and what to do next. Again, when you're thinking DIC, think about both clotting and bleeding. Both are happening typically at the same time. So diagnosis-wise, again, we need to assess our patient. What type of physical symptoms are we seeing? And assess for those etiologic factors, because we know it's not happening spontaneously. And then we're going to start sending off some labs. And this is where all those little coagulation studies that we talked about come into play. Our bleeding times are going to be prolonged. Prothrombin time over 12.5 seconds. That's abnormal. Platelet count is going to be under 50,000 or less than 50% of baseline. aPTT, again, another clotting bleeding time over 40 seconds. D-dimer over 250. This one is elevated because it's telling us that there is a clot present. It's trying to break down all of these clots that have been formed. Fibrinogen is it's a clotting factor. It's going to be less than 100 typically, which is really quite low. And this is telling us we don't have as many clotting factors around. If we're seeing the bleeding with DIC, we're going to see hemoglobin and hematocrit numbers reduced. Renal enzymes and liver enzymes are really just going to tell us, how are our organs doing? Are we concerned that we sent a clot to the kidneys? Are we concerned that we are not perfusing our kidneys or liver well because of hypotension due to bleeding? What's going on? So we can send those panels as well. Overall function, because this condition has the ability to affect every single body system, as we saw in that assessment slide. So what are we going to do? Before I pull up this next slide, one of our main goals is going to be preventing end organ damage. We talked about how there's potential for a lot of organ perfusion issues. So we want to prevent any end organ damage. We can be on a fast track to MODS, or multi-organ dysfunction syndrome, with this condition. We want to assess the cause. What's actually causing this? Can we mitigate some of that cause factor? And then we likely are going to need to give our patients some clotting factors back, probably give them some blood back if they're bleeding. So that's where I want to talk about what types of transfusions we use for certain coagulopathies. So before I put the slide on for this, I just want to talk through what blood products we use for what coagulopathy and kind of have it be a little bit more interactive. So if our hemoglobin's low and our hematocrit's low, we give red blood cells, right? That's our cure for that. We all know that. We give blood when our blood numbers are low. Platelets are also a little bit obvious. When our platelets are low, we give more platelets. Now, we usually wait till platelets are really, really quite low. But either way, if we're at that point that we need more platelets, then it's easy. We give platelets. Can someone tell me, out of these coagulopathies, which one are we typically going to give FFP for? Or which few? FFP is another one we give, and we're usually going to give it, if we're giving lots of blood transfusions, we'll give FFP anyway, just to keep everything really in balance. But what number is going to tell us FFP is really what we need? Good job, Lawrence. not fibrinogen. We'll get there. Yeah, so what we're looking at are our bleeding times or our clotting times. So our INR is a big one that we look at. So a lot of you put that in there. Excellent job. INR, PT-INR, aPTT, these are addressing that clotting cascade and telling us we don't have clotting factors to have a normal clotting time. So that's when we can give FFP because FFP is just chock full of clotting factors. So that is what we're going to use. If we see those prolonged times, the time measurements, PT-INR and aPTT, we are going to be thinking FFP. Now, what product do we give when our fibrinogen is low? There's a product, blood product out there that has lots of fibrinogen in it. Nice. I'm so impressed. Absolutely. Cryo, right? Yes, this is where cryoprecipitate comes in. We usually send it in response to that fibrinogen level. We would like to see fibrinogen get greater than 200. It's the typical goal for fibrinogen. Awesome. Now we can also send off blood levels for other clotting factors. They usually take a little bit more time. They're a little bit more nuanced, but that way we can give specific clotting factors as well if we need to. Okay, excellent job. So we're talking about DIC management. We prevent organ damage, treat the source, and then start to manage them. And we can do that with blood product transfusion, depending on what all of those coagulopathies are. And then we can also use some medications like antithrombin 3, assuming that there's a more of a clotting problem happening, heparin for extensive clotting, support blood pressure and volume. So this person likely is needing IV fluids and maybe inotropic or vasopressor support as well. The treatment for DIC can be very, very involved. The person is really quite sick. Okay, awesome job, everyone. Let's keep on moving. So that's DIC, disseminated intravascular coagulation, consumptive coagulopathy. We are triggering that coagulation cascade, putting it into overdrive, creating tons of clots, which cause problems, and then losing all our clotting factors, and we are having bleeding, which is obviously also a problem. So that is DIC. Let's move on to ITP, which stands for idiopathic thrombocytopenic purpura or immune thrombocytopenic purpura. So this is where we have got, with thrombocytopenic, we know we're talking about a reduction in platelets. And with this, we're seeing some sort of immune-mediated response to that, or it can be triggered by some medications. And we'll talk specifically about heparin here a little bit later. In the next section. So what we're seeing is thrombocytopenia. So our reduced platelet count is below normal. Anything below normal, 150,000 is our normal count. So it's below that. With this, I think both of these names are appropriate, but I do like immune thrombocytopenic purpura because it is an immune-mediated response. Our leukocytes are attacking platelets. Now, sometimes we don't know why they're doing that, which is why idiopathic is still appropriate, but I like the emphasis that there is an immune system condition happening. Whenever we know that, whenever we put something in the category of autoimmune, we can kind of make the treatment, like put it in a certain category for treatment as well. How do we handle other autoimmune conditions? So we'll get there in the next slide, but I like to emphasize on that just a little bit because it helps me remember exactly what's going on. Lymphocytes are activated against platelets, leading to platelet destruction. Again, we don't totally know why those lymphocytes are activated, but they are. It could be an infection triggering the inflammatory response in somebody who's a little susceptible to that autoimmune kickoff there. Pathophysiology, we're going to see an impaired clotting cascade because we don't have platelets circulating nearly as much of them, leading to bleeding. Common areas of bleeding that we can see are GI bleeding and cerebral. So that's how we're going to assess these patients. What type of symptoms are we seeing? Now, with thrombocytopenia, one of our most common symptoms for anything going on with platelets is that petechiae. As soon as we've got low platelets, we're concerned for that. So that's why we could see it also in DIC. Tiny red spots on our skin and mucosa. It's not there every single time somebody has thrombocytopenia, but it is a good tell. Bruising, unusual bleeding, gum, epistaxis, again, nosebleeds, where we don't have platelets to participate in that clotting. And we talked about with the clotting cascade how important platelets really are. They're the ones adhering to that site, changing shape, and degranulating, which is releasing a lot of blood clotting factors into the bloodstream. So they play a huge role. If we don't have enough of them, our risk for bleeding goes way up. System-wide, again, we're concerned for a couple things. Where are we going to start bleeding? Are we going to see stroke symptoms and a reduced level of consciousness? Are we going to see hematuria, meaning we've got some sort of bleeding happening in the kidneys? Do we have any GI bleeding? Melena versus hematoemesis. Both of those might be indicative of an upper GI bleed. Or are we seeing frank red blood exiting the GI tract for a lower GI bleed? Platelet count is typically going to be under 30,000. So even though it can be diagnosed as soon as it's low, and we don't know what else is causing it, we're typically seeing a significantly decreased platelet count. Other CBC numbers and coagulation studies are normal, and that's kind of helpful to know because when we draw those labs or we're seeing these symptoms could kind of look like some of the DIC symptoms we saw, right? But when we send off a coagulation panel, we should really only see that the platelets are decreased, not everything else. And that will help us differentiate between this and something else that's going on. Okay, management-wise, this normally is not going to require a ton of invasive treatment. It normally will kind of resolve spontaneously because the platelets, even with their under 30,000, we can usually still get by without major symptoms. Now, if we are starting to see symptoms, that's when we're going to start to manage this a little bit more aggressively. And these first two treatments relate to the fact that we're talking about an autoimmune condition. Corticosteroid management, and if really severe, we'll do IVIG. Both of these are corticosteroids are going to suppress that immune response, so simmer down how the white blood cells are attacking the platelets. And IVIG just totally suppressed that antibody response in the plasma. Platelet transfusion, if needed, again, we usually wait till platelets are quite low, 10-ish thousand or so, under 20,000 usually. And then if nothing else works, we can remove the spleen to really subdue that immune response. Nursing management, big thing is bleeding precautions. So caution with shaving, brushing teeth, etc. Prolonged pressure when you're removing IVs. Any sort of stick is going to be at an increased risk for bleeding. Frequent assessment and monitoring. See if we're seeing those signs. We might do more frequent neuro checks to assess for bleeding in the cerebral area. So kind of similar, but we actually know what's going on with this one. We've got heparin-induced thrombocytopenia. So our problem is still the same. We don't have enough platelets, but the reason for it is a little bit different. Heparin has triggered a response in the body. Now, it's important to emphasize that we have two types of HIT, and there's one of them that we care a lot more about, but we're going to differentiate between the two. In type 1 HIT, we have non-immune mediated heparin-induced thrombocytopenia, or HIT. This is luckily the most common because it's not severe. In type 2, our difference here is we are immune mediated. So something's going on with our immune system. We've triggered the immune system to attack the platelets. Excuse me, with non-immune mediated, the body just has kind of an interesting response to the heparin being on board. There's a mild decrease in platelets that's usually occurring pretty early on after we start heparin. So day 1 of heparin therapy, we send labs the next morning and our platelets have taken a small hit. They aren't crazy decrease, but they're lower than they were the day before. That's the platelets just kind of reacting to the fact that heparin is now on board. It's asymptomatic. The condition's going to reverse itself. We typically are not stopping a heparin infusion or sub-Q heparin if that's what we started when we are in this area, in this type 1. Now, type 2 is immune mediated, which means it's not going to resolve itself. If our body's attacking the body's attacking the platelets, we need to be a little bit more aggressive about managing that. Now, the differences on how we will be able to tell, well, are we in type 1 or type 2? First of all, we're going to see a severe decrease in platelet count. So instead of it just going down by 10, 20, 30,000 platelets, we're cutting those platelets in half, or 50% of our platelet count prior to heparin start. This is also going to occur a little bit later on in treatment. Occurs 3 to 4 days after heparin exposure. Takes time for those antibodies to develop. Those antibodies with any sort of immune response, they take time to be sensitized to whatever they don't like, whatever antigen they don't like, and form a response to it. That takes some time. So we're going to see this a little bit later. Symptoms of clot formation and significant clotting risk. Heparin must be discontinued. Now, the reason for that is those antibodies, those heparin antibodies in type 2, are not just reducing our platelet count, they are stimulating those platelets. They are going to cause them to release those clotting factors and stick together. They're going to aggregate, and that is going to increase our clotting risk. That's pretty bad. If we've got somebody who's on heparin, there's usually a reason they're on heparin. Maybe it's AFib. We're trying to prevent a stroke with their AFib. Maybe they had a pulmonary embolism. There's some sort of reason that we've got them on heparin therapy. And now they're having this reaction that, again, not only just decreases their platelets, but activates them and actively increases our risk for clotting. So this is a pretty dangerous situation to be in. And that's why we are definitely discontinuing heparin as soon as we see that this has occurred. Again, we can't usually see that it's occurred until 3 to 4 days later, which is unfortunate. But once we know it's occurred, we stop that heparin. So what are we going to see? We're going to see symptoms of a clot burden in the body. Those platelets are activated. Even though they're decreased, they are activated. So they are going to be trying to clot. So where do we see symptoms of clot burden in the body? DVT, PE, stroke, MI, impaired limb perfusion. We know all of that, right? We're looking for those classic clot symptoms. We can also send off some more specific lab tests like assays, platelet activation assays, hit antigen. So we can actually test for if that antigen is present, which is very helpful. Management-wise, we're discontinuing heparin administration. This goes for whatever form the heparin is in. Are we giving sub-Q heparin or are we on a continuous infusion of heparin? Either one, we need to stop it. Now, we usually are going to start some sort of alternative anticoagulation because that person was anticoagulated for a reason to begin with, and we know that they're now a little bit more susceptible to clotting. So we're going to start something alternative. This is typically going to be a direct thrombin inhibitor like argatroban, which is going to bind to and inhibit thrombin. It works differently than heparin, but still causes those anticoagulant effects without the risk of HIT. Only administer platelets if the thrombocytopenia is severe. We're at a big clotting risk. We don't necessarily want to give more platelets unless we absolutely have to. And that's why we'll wait until those platelets are really, really low, because we don't want to increase our risk for bleeding when we're already in a state of increased risk. So nursing management, monitor for these complications. Where are we seeing clots develop if we are? And ensure no further heparin exposure. That's really up to us. Make sure those orders drop off the MAR. The provider will discontinue them. We want to make sure that when this is discovered, they still don't have some sub-Q heparin dose hanging out anywhere. Okay, awesome job. Those are our big 3 coagulation disorders: DIC, ITP, and HIT, especially when we're talking about things that you can imagine seeing on the CCRN test plan. So let's talk briefly here with our last few minutes. Let's talk about pharmacology. We use a lot of pharmacology in the ICU in general for our patients. There's lots of reasons out there that patients need to be anticoagulated. That's what these are referring to. That's the pharmacology we're focusing on, is anticoagulants. Now, it's important to know some of these differences between each anticoagulant. It's helpful to know what factors they're working on. What's really important to know is what labs are we assessing to assess for therapeutic levels? And if we go too far, what are we using as a reversal agent? So let's start here with heparin. Heparin is going to bind to antithrombin 3, and it's inactivating thrombin, which is factor 2A. Prothrombin was factor 2. And it's affecting factor 10A, which is going to effectively slow down clot formation. With that, in your experience, what lab assessments are we testing to see if we're on a therapeutic level of heparin? Way to go, Lucas. You just gave me all the answers I could have ever asked for. Yeah, absolutely, everyone. So it depends. Some of this depends a little bit on your facility. I've worked in places that it is, we send different things off for heparin. So the two options for our lab value assessments are aPTT, that prothrombin time, because it's affecting that thrombin factor. So we're sending off aPTT. Or I said prothrombin time, and I meant thromboplastin time. Prothrombin time is PTINR. So aPTT and then anti-10A. Yes, we can send off an anti-10A level to just see how we're doing with affecting factor 10A. So absolutely. As far as a reversal agent goes, what reversal agent do we use for heparin? Perfect. Yeah, protamine sulfate. Absolutely. So that's going to be our reversal agent. Does um does heparin stick around for long? Do we have to worry about it being in the body for a really long time? No. Yeah, so this is really good for if we want to anticoagulate somebody, but we think they might be going to surgery in a day or so, we can keep them on heparin, turn that heparin off prior to the procedure. Depends on the procedure, depends on the surgeon, depends on a lot of things on if you turn it off 6 hours before that procedure, or sometimes I've had it where we turn it off right before they roll down to the OR. Kind of depends again on exactly what they're getting done. Um, with heparin, we're obviously having to monitor for HIT because it's heparin and that can cause that, obviously. So let's move on to low molecular weight heparin or enoxaparin. This is acting similarly because it is a form of heparin. It's primarily inhibiting that factor 10A, and it has a longer duration. So we are typically giving this in a subcutaneous shot form, more for chronic management of a clot burden. If somebody comes in with a DVT or maybe even a pulmonary embolism and we want to send them home on some sort of anticoagulation, we can do that with low molecular weight heparin. Now, warfarin is going to be a little bit different. Warfarin is going to inhibit at vitamin K so that we can reduce the synthesis of vitamin K dependent clotting factors. Vitamin K is hugely used by clotting factors to be synthesized. So it's going to affect quite a few different factors here, therefore delaying anticoagulation. What are we going to assess for warfarin? Yeah, awesome. PTINR, right? aPTT is assessing one part of the clotting cascade that heparin interacts with. PTINR is assessing a different part of the clotting cascade that warfarin interacts with. So that's why we've got those different assessments for these different medications. What are we going to give to reverse warfarin? Yeah, absolutely. So yeah, we're going to give vitamin K. So that's a good thing because the thing with warfarin is this is a very common chronic anticoagulant that we give our patients. Somebody's on anticoagulation, maybe even lifelong. Let's say they had a mechanical valve replacement, atrial fibrillation, whatever the reason is, they're on lifelong anticoagulation. Warfarin's a great option. We can get them to a therapeutic level. They can come in and have that level assessed. It is good for prolonged support. Now, what if we get somebody comes in, they're on warfarin therapy, but we need to take them to surgery? This is not going to be out of their system nearly as quickly as something like a heparin. So that's when we can use vitamin K to reverse it. With heparin, if we are acutely managing anything, oh, I haven't even been giving the answers as I've been going through this. There we go. If we have been giving giving, oh gosh, I just lost my train of thought. If we are concerned for an acute clot, so let's say we're concerned for pulmonary embolism, we're concerned for DVT, heparin is a much better option to acutely manage that clot than warfarin, because warfarin is going to take time to get to that therapeutic level. We don't really have time if we've got an acute clot burden. Heparin is going to be much, much better. Now, finally, here we've got our DOACs, direct oral antithrombin or anticoagulants, and they work with thrombin, directly inhibit factor 10A, preventing that conversion of prothrombin to thrombin, disrupt the final step of clot formation. This has become a lot more common because they're oral, which is great. So it's another way to more chronically manage someone's anticoagulation. Again, not a standard test. Sometimes they do anti-10A because it's affecting factor 10A. They are not reversible. We don't have a good reversal agent for DOACs. But again, no routine monitoring. You might assess your renal clearance, but either way, otherwise, it's a pretty easy drug to give, which is nice when we're talking about anticoagulation. Okay, that went by so fast. Overview of what we talked about today. We talked about the clotting cascade, kind of high level coagulation pathway. What labs, therefore, do we look at with our coagulation concerned patients in the ICU? How do we look at DIC? What's the pathophysiology behind DIC? How is it triggered? What are our concerns being clotting and bleeding? And then we looked at two types of thrombocytopenia, immune-mediated as well as heparin-induced, and how we go about managing those two conditions and the differences between them. And then finally here, we just spent a little bit of time talking about some common anticoagulants, how they work, what labs we assess, and what situations they're appropriate for. I skipped over this slide, but it's because we talked about it. Transfusion management, PRBCs we're giving for hemoglobin and hematocrit. Platelets we are giving for reduced platelet count. This is what we're giving FFP for, our all of our timed coagulation studies. And cryo we're giving for fibrinogen, which y'all had such a good understanding of, which is honestly a big deal. Not everybody does. And I remember it took me a long time to learn it too. So thank you so much for being here. Let me drop in, with this being a CE webinar, we have a post test. It takes like 2 seconds, where you can just put in whether this was helpful. Did you learn anything new today? Just give us some insight on how it went for you. And we have our next webinar next Tuesday, same time. We've got webinars every single Tuesday at 1 p.m. Central Standard Time this month in July. So really consistent timing, which is kind of exciting. And it's going to be back to our 30-minute quick practice questions. We're just going over any practice question and talking through them all together. So a little bit more interactive in those ones. If you are into that sort of thing, then these are. I know it's just a lot of me lecturing. So thank you guys so much for being here. I'm so glad it was helpful. Thank you. And we will see you in the next one. Definitely click that link if you can and take that evaluation, and then we'll get you that certificate here in the next, it's usually done in the same day. So you should have that in your inbox here soon.